Welcome everybody. We're going to go ahead and get started. I value your time and we just appreciate you coming out today. My name is Emily Watson. I'm the Marketing Director for Corporate Regional and Sterling Physician Group. You guys are the first lunch and learn in person that we've done since the pandemic hit. So we were super excited to get back. Most people find these to be a really helpful way of just learning more information before jumping in to a big surgery, because this could be a big surgery if you end up with a knee replacement. But we've got a great physician that I want to introduce you to, and he brought with him some really cool toys to Moultrie when you came. The most expensive toy you will ever see, but that's the Mako surgical robot. You don't like to call it a toy. It is most certainly not a toy. It's a very sophisticated
It's a productive toy.
piece of equipment, but it's the only one in South Georgia. He's going to talk more about that in his conversations. But this is Dr. Frankie Davis. We love getting new physicians, but we really love getting new physicians that have roots here in Moultrie. And he married a Moultrie girl, Anna Aguero, so we're counting on you to make sure he stays here long term. You got it. Good deal. Okay. So, we're excited to have him join our medical staff. I think you're going to be incredibly impressed when you hear his talk today. So, without any further ado, Dr. Frankie Davis.
Thank you.
Wrong one. There you go.
All right. Thank y'all for coming. As you said, Frankie Davis. I'm originally from Macon, and I did my undergrad training at the University of Georgia back from 2007 to 2011. And then after I graduated from undergrad, I reconnected with my wife, Anna, while she was at Auburn, and we started dating, and then got married after my first year of med school at MCG, so Georgia Public School route. And then we moved our family to Chattanooga, Tennessee after I graduated from MCG, and subsequently did a 5-year residency there and very much enjoyed it, and grew our family by one. So now we have 2 kids. Trey's 7 and Ellie's 2, and she kind of runs the show. But about, I guess around my 2nd year of residency, we were discussing where we thought we wanted to end up. Talked about Chattanooga and talked about Greenville, South Carolina, talked about Augusta and Athens some, and then the conversation quickly diverted to we're moving home. So we ended up having an agreement with the hospital around that time, and this has represented kind of the final line of our training journey. And now that we're here, it's somewhat surreal, and I'm super thankful to be here and happy to be a part of the community. So today what we'll do is we'll talk about knee pain. This will be a fairly quick but somewhat comprehensive talk discussing the different sources of chronic knee pain, specifically arthritis and the types of arthritis that present. We'll talk about the conservative management of these problems briefly, and then we'll dive into the more interesting part of the talk, which is knee replacement and how the Mako robot contributes to the way we treat knee arthritis now. Hopefully my little clicker will actually work. Yeah, there we go. So super awkward picture of me and all the things that I just said. Walk me through it. So, as I previously said, we'll talk about the things regarding knee replacement, and then focus on recovery and expectations, and then we'll take a little time at the end to answer some questions too. So, people here who are suffering from knee pain, or if you know people who do suffer from knee pain, this can be a horribly debilitating problem. It is not an emergency, or it is not even necessarily an urgent thing that is dealt with, but it can affect you every single step. And when something is causing discomfort and pain every step, it very much contributes to your ability to enjoy the things that once gave you pleasure, but also to kind of function on a day-to-day basis. So it's become a primary concern and has been for a while, which is why orthopedic surgery, our research, and a lot of financial backing goes towards trying to make this operation better. So 3 main causes of chronic knee pain, one being rheumatoid arthritis. Rheumatoid arthritis is a little bit different than the wear and tear arthritis. Essentially what happens is your immune cells target the synovial tissue around the knee joint, and that causes erosive change and eventual degeneration of the cartilage. That's a fairly similar outcome, although it's a different process to the typical wear and tear arthritis, which is the most recent or the most common reason why people come into my office for knee pain. That's basically just wear and tear. You're born with a certain amount of tread on the tires. Andrea, who's back there in the back's heard me say that 1,000 times. And that wear and tear wears out, and we have not developed a way yet to do an injection that regrows cartilage. There's a lot of research being devoted to that, but I don't think we're anywhere close. So when the cartilage is gone, then you develop bone-on-bone contact, and that contact is not normal. It's not something that we're capable of tolerating, and it causes quite a bit of discomfort and deformity. The final way people present with chronic knee pain is after you've had an injury to the knee. This is much less common, but when you have an injury to the knee that disrupts the articular surface, then you have jagged edges of bone that are grinding together, and it is no longer a smooth bearing, so they can develop arthritis that way as well. That's called post-traumatic arthritis. There are quite a few non-surgical things that can be done. These are all essentially a Band-Aid to try to delay the inevitable, but those things can be use of assistive walking devices, whether that be a cane or a walker. That is not an ideal strategy typically, but can buy time if necessary. You can also try ice therapy that decreases inflammation, specifically with rheumatoid arthritis, because that cycle can kind of build up and make things worse and worse. And if you can taper that inflammatory cycle, then you can relieve pain. You can also work with physical therapy to help improve the mechanics around the knee joint, although that doesn't repair the problem that's going on inside the joint, so it's also sort of a Band-Aid treatment. We also typically use oral anti-inflammatory medication. You've all heard of ibuprofen, Aleve, meloxicam, Mobic, naproxen, the list goes on and on. Those things work well, but eventually the conservative management is going to be exhausted, and then the discussion is had about whether or not you're ready to move forward with an operation. So that discussion can be fairly difficult because this is a big thing to undergo. There are complications associated with it, which we can talk about later if needed, but it's a big decision. You're going to be down for 6 to 12 weeks. It's going to take time to recover. So we need to have a discussion about when it's time to make that decision. And several things go into that discussion. I think if it's waking you at night, it's making it difficult for you to sleep. If you're having a hard time doing the things that once gave you pleasure on a day-to-day basis, if it's inhibiting your quality of life, then I think it starts to become time to talk about the risks and benefits associated with undergoing the operation. So that leads us to what is the operation and what is involved. So I think it's important to talk about the anatomy associated with the knee joint. It's essentially your femur bone and your tibia bone, which is your thigh bone and shin bone, that articulate with each other in a hinged mechanism. You have your kneecap or patella that allows for you to maximize the mechanics of your extensor mechanism, but that also articulates with the femur bone as well, and that makes up the three compartments of the knee. So you have the medial compartment, which is the most common compartment to be abnormal, the lateral compartment, as well as the patellofemoral compartment. As you can see on the left side of the screen, you have healthy articular cartilage, which is represented by the white tissue. It is fairly spongy and is fairly soft, so those surfaces articulate really smoothly and well. When it becomes pathologic, you develop exposed bone, and that exposed bone is very painful. There's a lot of nerve endings there, so when you have bone-on-bone grinding, you can imagine that would be much more uncomfortable. And it's sort of a snowballing effect. As you get more bone-on-bone arthritis, you get more inflammation, it breaks down more cartilage, and that process can be extrapolated as it develops. So here are some radiographic images. I apologize, the right image is not showing up super well. I wonder if you could click both lights off for just a second, see if that shows up. Yeah, so there you go. So on the left side of the screen, you can see this is a AP view. Top of the view is the femur bone. Bottom of the view is the tibia bone or shin bone. The kneecap's here in the middle. You can see the space that remains. Radiographs show only bone. They don't show soft tissue, so you extrapolate based on the clear space that you see whether or not cartilage is present. On the left side of the screen, there's good healthy cartilage at the medial and lateral compartments, so this would not need anything done. On the right side of the screen, you can see this is the lateral compartment, this is the medial compartment. On the lateral side, there's healthy joint space remaining. The medial side, you can see it's bone on bone, there's no space remaining. You can also see that the bone is reacting to that increased contact pressure. We call that subchondral sclerosis. That's the body's attempt to bolster that increased contact pressure by laying down new bone, and that's a radiographic sign that there's a problem taking place. So this is what a total knee replacement looks like. It is a combination of a cobalt chromium femoral component. This is a partial, which we can talk about briefly, but this is the femoral component, which is made of cobalt chrome, which is a very wear-resistant product. And then the tibial component is a tibial tray that actually inserts in the tibia to maintain stability, and it's made of titanium. In between the two is a very wear-resistant, shear stress-resistant piece of medical-grade plastic called highly molecular weight polyethylene, and that's what we've started using in the last 15 years or so. We have really good long-term outcomes with that bearing surface now, up to 25 plus years in some of our studies now, which is really nice. The rate of knee replacement is rapidly increasing. I believe last year we did over 600,000 total knees in the United States, and that number is expected to increase to around 1.5 million by 2025. So it's a much needed procedure. It's a big problem that's plaguing the U.S. and other parts of the world, which is why I think it warrants a discussion. So this is just a quick summary on partial knee replacement. As I said earlier, there are 3 compartments. Sometimes only one compartment or 1 or 2 compartments are diseased, and you can directly address the individual compartment. As you can see here, this is medial compartment arthritis, lateral, patellofemoral, and then a dual compartment. You can replace those individually. There's a little bit more stringent criteria, but the robot makes that procedure quite a bit easier as well, which we'll talk about in a minute. Here are some radiographic images representing what knee replacement provides on a radiograph, and I think it's interesting to compare to the previous x-rays we looked at. This is a partial, which we'll kind of glaze over. This is a total knee, which is the cobalt chromium femur, the titanium tibia component, and then the plastic bearing, which kind of represents the articular cartilage between the 2 components. So now, this is, in my opinion, the more fun part of the talk. This is a discussion about the Mako robot, as you can see on the right. This is a robotic arm that's used in surgery and is operated by me throughout the case. There will be a quick little video that explains it, and we'll dive into it a little bit further. I forgot about this slide, I apologize. So this is discussing how prevalent the Mako has been in the United States. Because it's new technology, people feel like it hasn't been validly tested or implemented into the marketplace, and that is not the case. Stryker purchased Mako, I believe, about 15 years ago, and it has had a great track record underneath the Stryker umbrella. However, it was still in service for unicompartmental replacement with another company for almost 10 years before that. So a lot of good literature, and what they've proven is that you have early recovery, better participation with physical therapy early, better postoperative pain scores, which I think are big positives. They also have noticed that the implants have been placed more accurately with less errant bony cuts, so the soft tissue around the knees are more protected. It requires less soft tissue dissection to balance the knee, so all those are big positives and are kind of pushing the technology forward. So as I previously said, this is the Stryker data that they post. 14 plus years, 300 plus thousand total knee replacements placed by the Mako. There's almost 1,000 systems placed across the country. We are in a little bit of a vacuum area for the Mako. There's a Mako in Macon, there's one in Tallahassee, but otherwise Southwest Georgia is not really represented, so I'm excited to bring it here, which is nice. All right, here's the little video. Hopefully it works.
Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of x-rays taken at different angles that can help surgeons see things that they can't typically see with an x-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the Mako system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the planned size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. and visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space, and once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
So as you can see, the Mako technology has changed the way we do knee replacement. It doesn't necessarily make the procedure different. However, the points during the case that were previously basically anatomic guesstimations have now been narrowed to improve the accuracy of the implant. And the reason that's important is because one of the largest complications associated with total knee replacement is continued instability, particularly at dynamic points of motion around the knee, because it's a complex multiplanar motion that occurs in the knee. So this allows you to improve the balance and minimize the need to do soft tissue balancing that causes postoperative pain. So it's really improved that, and I think we'd be foolish to not utilize something that makes us more accurate and safer, and I believe this does both of those things.
Frank, a quick question. Do you
Yes,
still
sir.
need the ACL, MCL, PCL to have a good knee replacement?
Great question. So there's two implant types you can have. You can have a cruciate retaining, which is only the PCL, and you can have a cruciate substituting. So if the PCL is determined to be incompetent, then you would likely select the cruciate substituting implant. They're slightly different, but have similar outcomes, but you do not require the ACL. The ACL is sacrificed anyway. I think that's what you were digging at. Yeah. That's a very important question though. So after surgery, it's a fairly stringent early postoperative recovery period. For the first 6 weeks, you'll be focusing on attempting to regain your motion, trying to minimize swelling, working with therapy to get that inflammation down about the knee. It's my responsibility to minimize the soft tissue insult that I place in the soft tissue compartment around the knee. But after that, it's not only my job, but the patient's job as well as physical therapies to minimize inflammation, decrease swelling, and begin initiating range of motion. The thing that is interesting is in recent years, we've begun our postoperative weight bearing immediately. So you'll have your surgery, wake up in the recovery room, receive some pain medicine, and then that same day, physical therapy will get you up and you will walk on your new implant. And people know the day they have the surgery that the pain that you've been dealing with for years is now gone. It's a different pain because you have recently had surgery, so you will be uncomfortable, but it's a very nice immediate satisfaction knowing that that pain that has been detrimental to your day-to-day activity is gone immediately. So after your hospital course, typically now it only requires 1 day in the hospital, then you'll be able to go home. You'll see me at the 2-week visit. That'll just be a swelling check and a skin check. I'll check your incision to make sure that it's healing appropriately. After that, you'll go to therapy, and the 2 to 6 week mark is time to make some progress. You'll work on range of motion, also with focus to decrease swelling. And then at around the 12-week mark is when I tell people that we'll start to be friends again. We're friends before surgery, not great friends immediately afterwards. For the following 6 to 12 weeks, I start to reel you back in, and then at the 12-week mark, you're feeling good about it. But from the 3-month to the 12-month mark, that continued improvement will happen. And then around the 10 to 12-month mark is when you start to sometimes forget that you even had the procedure. So people begin to be really thankful at that point in time. That's the typical progression. It can be more rapid or a little bit more delayed depending, but that's typically how things go. And then the end goal is to do what you want to do. We're trying to get you back. Traditionally, we would limit weight bearing, we'd limit activity. The implants have really improved. Our cement interfaces have really improved. The polyethylene plastic bearing has significantly improved, and our wear rates are better. So we really don't restrict activity. Hiking, running, cycling, playing sports, playing golf, getting back to doing the things you love are the reason we do the procedure. So I think it's a great operation, and I'm glad we've brought this technology to this area.